All right. Well, good afternoon, everyone, and it is my pleasure to discuss with you the role of MRI in diastolic dysfunction. So, a few years ago, we were actually invited to participate in this special issue on a state-of-the-art review about MRI in evaluating HFpEF and diastolic dysfunction. So we actually started talking about the role of MRI in left ventricular mass and hypertrophy, how we can actually have additional strain data from MRI using feature tracking, how we can also look at the cellular level and look at the evidence of interstitial fibrosis with T1 mapping and extracellular volume mapping, how we can get an accurate assessment of left atrial volume, and so on. Acquire contiguous short axis images of the heart. We trace the epicardium and the endocardium, and then the volume between the epicardium and the endocardium is going to be the left ventricular volume, and mass by definition is going to be this volume multiplied by the specific gravity of the myocardium, which is 1.07. When we talk about myocardial hypertrophy, we talk about the 1 in 500 prevalence of hypertrophic cardiomyopathy. This is kind of the classic description of the reverse septal curvature, where the mid septum is actually thickened and hypertrophied, in this case, with sparing, which is sparing the lateral wall. And more importantly, you could actually see on late gadolinium enhancement, the classic patchy myocardial fibrosis involving the RV insertion site and extending to the myocardial hypertrophic segments. This is basically exactly what we see on autopsy study with this asymmetrical septal hypertrophy of the left ventricle, along with myocardial fibrosis in white. Now, the hypertrophic hearts that we see on MRI, the one size does not fit all. So we have the basal septal hypertrophy HCM to the more diffuse hypertrophy of the HCM, the apical HCM, the subaortic stenosis. We also have the amyloid cases and the endomyocardial fibrosis. How do we discriminate between all of these? This is where MRI with tissue characteristics plays a role. You could see actually the classic LGE that's patchy and diffuse in the HCM cases. You can see the global subendocardial enhancement and mid-myocardial enhancement in the amyloid. And you could actually appreciate the cases that are mostly hypertension heart disease, where some of those people might have scar and majority of them will not have scar imaging. The most important take-home message is that when the hypertrophy is limited or segmental, the left ventricular mass is usually within normal limits, which really underscores the importance that substantial cardiac mass is not a diagnostic prerequisite for HCM. We've been actually measuring flows and with MRI using a technique called phase contrast imaging for many years. Unlike echocardiography, where we sample volume and we deliver an ultrasound beam in parallel to the blood flow in order to estimate flow across. In this case, we actually, in MRI, we directly measure the blood flow through an en-face image or perpendicular to the blood flow. By definition, flow is going to be velocity times area, And when you take a look and take into account flow over time, is going to give you volume in cubic centimeter. This is actually the way that we do it. We actually create a phase contrast, a phase image, and a magnitude image. This is going to show us the anatomy. This one here is typically going to show us the velocities of those protons that are spinning, and they're spinning with basically different shift in the phase that they acquire after applying an external magnetic field. We can also measure the velocities across the mitral valve, as you can see here, by prescribing a plane perpendicular to the mitral valve on a 4-chamber view and a 2-chamber view. You're going to get a phase image that's showing you the mitral inflow and a magnitude image, and you could actually derive on this time activity curve, where basically the x-axis is going to be time, and then the y-axis is going to be the velocities, and then you can see the area under the curve over here is going to give you the flow, and you could actually derive an E wave and an A wave. Now, we do know that there is significant underestimation of velocities using MRI because, number one, there's the dynamic nature of the mitral annulus. Number two, the imaging plane is not perpendicular to the blood flow completely. We also have a signal loss in turbulent jet, say stenosis or regurg, along with a lower temporal resolution of 33 milliseconds compared to less than 10 milliseconds using Doppler echocardiography. Strain, as you all know, is defined as the change in the myocardial fiber length between end diastole and end systole divided by the original length of the myocardium in diastole. We all know that from echo data for the past 2 decades, it's a very powerful diagnostic and prognostic marker for LV function, both globally and regionally. And for the past few years, with the adventure of feature tracking, we're actually able to track voxels of the myocardium, track their motion over time, and we're also able to kind of follow the changes that happen in the displacement. This is the short axis image of the left ventricle at the mid-ventricular level. This is a 3-chamber view of the heart where you can see the anteroseptum and the inferolateral. We do need a post-processing imaging software, but it can be done on any routine cine cardiac MR scan. Similar to how we can derive a longitudinal strain and a radial strain and a circumferential strain, we can do the same with feature tracking MRI, where you can create a bullseye map, and it's giving you at a regional level and at a global level what the longitudinal strain is and what the circumferential strain is. Adding to that, we could also now with 3D, we can actually generate this heat map and look at the 3D myocardial strain at any anatomical location that we would desire using this post-processing imaging technique. Moving on to myocardial fibrosis, we know that MRI can provide a direct assessment of the replacement fibrosis that's typically that we see with the high signal intensity with delayed gadolinium enhancement, but even the interstitial fibrosis, which is the expansion of the extracellular matrix. It is believed that this is actually a major contributor to the impaired myocardial relaxation and increased stiffness that is seen in our HFpEF patients. We rely on one relaxation parameter called the T1 time, which is the course of the longitudinal magnetization recovery of the myocardium at the tissue level after we apply a radiofrequency pulse. We see a lot of those abnormal T1 values in anything that affects the structure of the heart, including hypertrophic cardiomyopathy, amyloidosis, diabetes, and these basically are associated with increased interstitial fibrosis. This is a normal heart at a mid-ventricular short axis level. We're measuring the T1 time at the septum. Anything less than 1,000 milliseconds is normal, versus this patient who has hypertrophic cardiomyopathy of the concentric type, and the T1 time has significantly increased up to 1,300 milliseconds. Using the T1 time of the myocardium pre and post contrast, and the T1 time of the blood pre and post contrast, because we know that contrast will shorten the relaxation time of the blood and the myocardium. And if I'm interested in looking at the extracellular volume, you can plot through this equation, taking into account the patient's intracellular component, which is the hematocrit, and calculate the patient-specific extracellular volume. We do it on the short axis image of the heart, and you can see this is a pixel-wide map of all the T1 times, and we're actually taking into account the blood T1 time and the myocardium T1 time. A normal extracellular volume is going to be less than 30 or 29%, versus an abnormal is going to be more than 30%. The higher the extracellular volume, the more likely that the patient has significant diffuse myocardial fibrosis and underlying increase in LV mass. When we take a look at this echo versus CMR parameters, looking at patients with HFpEF versus hypertensive heart disease, and we match them against controls, the extracellular volume was significantly increased in our HFpEF patients, 36% plus minus 5%, and in the hypertensive patients, but at lower degree, 31 plus minus 5, versus the control, who have had a normal extracellular volume of less than 30%. And the extracellular volume was actually a better discriminator than the GLS derived from echo to differentiate both conditions, HFpEF and hypertension, with a cutoff of 31%, a sensitivity of 100%, and a specificity of 75%. In this paper from a few years ago, we're looking at the relationship of myocardial fibrosis determined by CMR and outcomes related to our heart failure with preserved EF patients. It's a small subject study of 140. 96 of them were HFpEF and 44 were control. The focal myocardial fibrosis was seen in 50% of those patients. 3/4 were a non-ischemic in origin, meaning they did not follow a coronary artery disease distribution. The diffuse myocardial fibrosis was higher by 25%. If you look at those indexed ECV, 13.7 versus 10.9, and there were 42 composite events in this patient's cohorts. This is an example of the focal myocardial fibrosis we see here in this basal inferoseptum. We can also quantify those with post-processing imaging software tools. This is a patient with a mid-myocardial late gadolinium enhancement or replacement fibrosis, and this is a patient who has a subendocardial fibrosis in the inferolateral LV myocardium. Based on the increased quartiles of the indexed extracellular volume, your event-free survival, looking into mortality and repeat heart failure hospitalization, was higher in those patients who were in the higher quartiles of indexed extracellular volume, as demonstrated in this patient's cohort. Now, moving on to left atrial volume, we know that cardiac MRI is really the gold standard in chamber volume quantification. While being accurate, we have to understand that those volumes that we get on CMR are larger, similar to how our left ventricular volumes and RV volumes are larger in MRI. They're also larger for left atrial volume. We want to calculate the maximal volume index. Remember, the upper limits of normal is 53 ml per meter square for men versus 52 ml per meter square for women. Compare and contrast this by echo, which the upper limits of normal is 34 ml per meter square. We use the same formula with echocardiography, which is the biplane area length method, taking into account the area on a 4-chamber view. This is a 4-chamber view of the heart. This is a 2-chamber view of the heart. We actually measure the area, multiply by the fixed constant of 0.85, divide by the length. The volume in this patient's was 198, which actually goes to the severe left atrial volume enlargement in this patient with preserved ejection fraction. Similar to how we can measure volume, we can also look at the myocardial mechanics of the left atrium by looking at all 3 functions, the reservoir, the conduit, and the atrial function. And all of this basically can be assessed with MRI. You could actually generate those time curves, looking at volumes and time. You could also generate strain in those patients. The one that we typically report the most is the left atrial reservoir strain, because that has been associated with incident heart failure with preserved EF diagnosis and hospitalization. In this study from a few years ago in the MESA cohort, both the left atrial volume and function were predictive of the patients who would subsequently develop heart failure. The larger the left atrial maximum volume, but also the larger the left atrial minimum volume and your preatrial contraction volume were independent predictors. Can MRI assess filling pressures? A single center study enrolled 800 patients with shortness of breath and suspected heart failure to basically undergo a right heart cath and a CMR. they came up basically with a derivation cohort, and then they actually validated their findings. 2/3 of the patients had normal wedge pressure, 1/3 had an elevated wedge pressure. The CMR metrics were used were left ventricular mass and left atrial volume. The way that they came up with this formula is that they had to come up with a multivariable regression model, and then they derived an equation using those fixed constants multiplied by left atrial volume plus a fixed constant multiplied by the left ventricular mass. What did they find in those patients who also have had the same-day echocardiography is that the correlation between right heart cath wedge pressure and the CMR modeled wedge pressure was modest at 0.5, but they saw a poorer correlation in patients with HFpEF. They also concluded that the CMR modeled wedge pressure was actually specific in 92% with a negative predictive value of approaching 80%. It was associated with an increased risk of death with a 77% increase risk, and it was non-inferior to right heart cath wedge pressure to predict survival. So it has pros and cons. Number one, it has a good diagnostic accuracy, and it's promising when the transthoracic left ventricular filling pressure is indeterminate. But remember that they had a very high indeterminate rate in this single center study because they did not rely on all 4 parameters that we use for assessing and grading diastolic dysfunction. The limitations of using MRI is that it doesn't do well in our HFpEF patients. Number 2 is basically we do not really know the role of this in patients who have other types of underlying heart disease, whether valvular heart disease or arrhythmias. So there was a rebuttal and the work by Dr. Nagueh looking at 79 patients who basically have had a right heart cath and an echo within 1 week. Remember, the single center European study was the same day within 24 hours. 33 patients in this cohort had a wedge above 15, and we're trying to kind of answer the question of whether or not how good does echo versus CMR predict pulmonary capillary wedge pressure. We can see this patient who has a tall E wave and an A wave with an E to A ratio more than 1.2. He has a S less than a D wave on their pulmonic vein velocity, a markedly reduced septal E prime velocities, and an increase in the TR jet velocity, consistent with diastolic dysfunction, grade 2 with elevated filling pressures. And then this is the corresponding MRI of the patient calculating the left ventricular mass and the left atrial maximal volume index. So they actually used the same mathematical formula as was used in the European study, and they came up with a diagnostic accuracy algorithm. Echocardiography outperformed CMR, both sensitivity and specificity, and the positive predictive value and the negative predictive value was higher with echocardiography compared to CMR. The area under the curve for MRI was 0.72 versus 0.87 for echo, and that was statistically significant. Now, where does MRI add another potential role is basically in the workup of patients with HFpEF. This is a patient who has the classic sigmoid septal hypertrophy, hypertrophic cardiomyopathy with patchy myocardial fibrosis seen in this hypertrophic segment. But this is a patient who actually was diagnosed with HFpEF, but actually he has a thickened pericardium on this T2 weighted image, along with significant late gadolinium enhancement consistent with constrictive pericarditis. If we look at this ACC expert decision pathway for patients with heart failure with preserved ejection fraction, and when do we refer a patient to basically a cardiovascular or heart failure specialist? They use this acronym, which is called check-in. And you could see actually in the E, when extensive evaluation is needed, whether that was invasive hemodynamics, an MRI, or exercise testing, particularly if we have areas that we're concerned about hypertrophy in areas that we cannot easily see with echocardiography. That includes the anterior wall, that includes the lateral wall, or the patient continues to present with heart failure symptoms with an unremarkable echo. You want to basically look at the phenotype of heart failure in this patient's cohort. If we take a look at this patient over here who has a significant increase and concentric increase in the left ventricular wall thickness, they have a dilated left and right atrium, they have a small pericardial effusion. On cine CMR, this basically tells me that I'm dealing with one of those phenocopies of HFpEF. When I add tissue characterization with the late gadolinium enhancement, I can see that there is a diffuse classic near circumferential subendocardial late gadolinium enhancement, which is white. And that white basically is all myocardial infiltration. There's also significant uptake of LGE in the right ventricle and the interatrial septum. So this is basically a classic case of amyloid heart disease. Are there new emerging techniques in the horizon for MRI to basically look at quote unquote measurements of myocardial stiffness? There are, using the MR elastography, which is basically an external vibrating source that can generate shear waves. And then we can actually, using a 3D model, we're actually able to generate a myocardial stiffness map. There is also myocardial specific spectroscopies, which actually uses basically a different agents in order to look at myocardial energetics and myocardial metabolism. So these basically use phosphorus, and others use hydrogen, others use carbon. These are all basically the different agents that can be actually used in MR spectroscopy. Now, some of the limitations of MRI, obviously, is that, number one, it's a costly equipment. So thankfully here at Methodist, we have availability of all advanced imaging technique, but also there are people who might not undergo a cardiac MR because of claustrophobia. Still, basically, the length of the CMR examination might be a barrier, although now with the introduction of speed acquisition with compressed sensing, this might be better. Also, we have difficulties interpreting image quality, particularly ECV and T1 time, patients who cannot hold their breath, patients who have arrhythmias, and patients who have underlying devices or prosthetic implants. All of this can be a barrier to kind of provide a highly diagnostic image quality. But hopefully in this basically presentation, I was able to kind of walk you through all the diastolic function indices that we can use in CMR. But remember, CMR will never be the sole cardiac imaging modality for assessing or diagnosing diastolic dysfunction. With that, I would like to conclude, and I thank you for your attention.
Good afternoon. We'll talk today about diastolic function assessment. So diastole concerns two phases of the cardiac cycle: isovolumic relaxation, when both valves, aortic and mitral, are closed, and the pressure is dropping. In normal hearts, this pressure drop is very fast, and we end up with a very low pressure in the ventricle that is 0 millimeters mercury or thereby. During the filling phase, the aortic valve stays closed, the mitral valve is open, and as we notice in this pressure volume loop, the rise in pressure is a small magnitude compared to the rise in volume. It's what we call a compliant ventricle, or a ventricle with normal chamber stiffness, not increased. While I've presented diastole as events during isovolumic relaxation and LV filling, there is really interactions at several levels, from the cellular to the intact part, between systolic and diastolic events. In the cath lab, the way to assess the end-diastolic pressure-volume relationship and be able to compute chamber stiffness and, if needed, myocardial stiffness, we alter the venous return, typically by inflating a balloon in the inferior vena cava, and we end up with several points corresponding to different volumes and pressures. As you notice here, this is a curvy linear relationship. In comparison, the end systolic pressure volume relationship is a linear one. So that's what you can refer to as the basics of assessing diastolic function. Showing you an example here of pressure volume loops from a patient who had shortness of breath, but not from the heart. The venous return is altered, and we notice that the volume, the end diastolic volume, is changing over a decent range from 160 plus mLs to maybe in the mid 120s. And if you look at the end diastolic pressure corresponding to these volumes, it's almost identical. So that's a ventricle that is really compliant. In comparison, we see this upward slope of the pressure as the end diastolic volume goes higher. That was obtained from a patient who had heart failure with preserved ejection fraction, and when chamber stiffness was computed, it was increased. We do not typically do the pressure-volume relationships nowadays, except in research settings. More frequently, we measure ventricular pressures or atrial pressures. The lowest pressure in the ventricle is the minimum pressure. A ventricle that has rapid relaxation, that has good suction forces, will have very low minimum pressures. Once the mitral valve opens and left ventricular filling takes place, we see a rise in the ventricular pressure during this rapid filling phase, then more of a plateau, and then we see another increment in ventricular pressure when the atrium contracts and sends some more blood. The ventricular plateau pressure before the rise in pressure due to atrial contraction is referred to as pre-A pressure, the pressure that precedes the increase in the pressure of the ventricle during what we refer to as the A wave. The pressure at end diastole is the end diastolic pressure. The pre-A and end diastolic pressures can be measured reliably with fluid-filled catheters, but we need a micromanometer tipped catheter to look at LV minimum pressure reliably. And that's one of the challenges if one were to look at how we can reproduce these diastolic pressure relations. If we look at atrial pressures, the largest pressure in the atrium at end systole is the V wave pressure. At the first crossover point, the pressures in the ventricle and the atrium are equal. Then atrial pressure drops with opening of the mitral valve as the ventricular pressure is still dropping below the atrial pressure. And that pressure gradient triggers the flow of blood from the atrium into the ventricle through the open mitral valve. After that transmitral pressure gradient has been established, we have another gradient in late diastole due to atrial contraction. The atrial contraction is measured by the A pressure rise, and a good contracting left atrium would have a high rise in the atrial pressure. Then the atrial pressure drops because the atrial muscle relaxes, so we have the X descent, whereas in early diastole we have the Y descent. The dotted line is the mean left atrial pressure, and please notice it is lower than both the A wave pressure and the V wave pressure. That's an example of a ventricular pressure recording from a patient with hypertrophic obstructive cardiomyopathy, and the patient had significant symptoms of shortness of breath and NYHA class 3. We see here a minimum pressure that is about 17 millimeters mercury, a pre-A pressure that is 24. This pressure is normally around 12, and the minimum is normally around 0. Notice the end diastolic pressure is more than 32 millimeters mercury, whereas the normal range should not exceed 16 millimeters mercury. These pressure recordings tell us that the patient has the shortness of breath related to the cardiac etiology. Using echocardiography, we can look at the flows and try to infer changes in pressures from that. So in a normal heart, predominant filling in early diastole, E more than A, there is a rapid decay of that early velocity with a short deceleration time. Also, the velocity rises quickly in early diastole from 0 to the peak E, and that time interval is referred to as the acceleration time. So both the acceleration rate, which measures the velocity divided by time, as well as the deceleration rate, are typically, the time intervals are short, but the acceleration and deceleration rates are preserved or increased in normal hearts. The time interval between aortic valve closure and mitral valve opening is the isovolumic relaxation time. In a normal heart, the ventricle is relaxing well, pressure is dropping fast, and this time interval is short. With impaired relaxation, we notice that the pressure gradient in early diastole is reduced. And as a result, the E velocity is decreased with a long deceleration time, a rather long acceleration time, and a long isovolumic relaxation time. Now there is more blood in the atrium before it contracts, and that triggers a more forceful atrial contraction and therefore a higher A velocity. Thus, the E to A ratio is less than 1. If this patient were to maintain increased stroke volume, or if with a faster heart rate, or if we administer fluids, and the atrial pressure increases, and we get again predominant filling in early diastole with short deceleration time and short isovolumic relaxation time. This patient who would be clinically in heart failure gets effective diuretics, then the left atrial pressure drops and we revert back to that impaired relaxation time. So this change in mitral inflow pattern can be useful in diseased hearts to draw inferences about left atrial pressure. What about annular velocities? They measure the recoil of the annulus, which happens in an opposite direction to the flow of blood. So there is a brief, small recoil during isovolumic relaxation phase, then during early filling, then during late filling. With impaired relaxation, the E prime velocity is reduced, the A prime velocity is preserved or increased. With restrictive ventricular filling, which is the most advanced stage of diastolic dysfunction, both the early diastolic velocity and the late diastolic velocity are reduced, and these have been associated with worse clinical events. Notice that unlike the mitral E, when the left atrial pressure is increased, the E prime velocity remains reduced. This occurs because of a delay in the E velocity such that it occurs during the pressure crossover where the atrial and ventricular pressures are close, and thus it is protected, if you would, from the high left atrial pressure influence. The Doppler assessment of diastolic function and filling pressure has good accuracy if you look at patients with cardiac disease, but if you take normal subjects, you induce rapid changes in loading conditions, then these velocities are load dependent, and it becomes challenging to draw reliable conclusions in this setting. The ASE guidelines in 2016, in conjunction with the European Association of Cardiovascular Imaging, recommended that we should aim for the estimation of early left ventricular diastolic pressure, so meaning mean left atrial pressure, wedge pressure, and pre-A pressure. All these three pressures are very similar to one another. And why do we want to aim for these pressures as opposed to end diastolic pressure? Because these pressures are the ones that determine the filtration that happens across the alveolar capillary region, and that determines the development of pulmonary congestion symptoms and pulmonary edema. So there are also specific patient populations that pose challenges, and when we think of a guidelines-based approach to assessment of left atrial pressure and diastolic function, it depends if you're looking at a case that belongs to one of these specific populations or not. And they are listed on this slide. It doesn't mean that when we see patients with these conditions, we don't assess LAP or we do not aim to assess LAP. It just means we have challenges and we have a different approach from the general approach that I will be sharing with you now. So the first question, is there diastolic dysfunction or a high likelihood of diastolic dysfunction? And it is important to look at clinical information and what the left ventricle looks like. Is this a structurally abnormal heart? Do we see functional abnormalities or not? For example, someone can have hypertension or coronary artery disease with multiple segments, having wall motion abnormalities, increased wall thickness because of aortic stenosis or hypertension, or hypertension leading to increased wall thickness and left atrial enlargement. Be very careful with ventricles with systolic dysfunction. We said there is an interaction between systolic and diastolic function. The caveat to the issue of systolic dysfunction and diastolic dysfunction in that setting is we want to make sure we are not looking at an athlete's heart where you can see low normal EF or even high 40s ejection fraction, but it is nevertheless a normal heart. This is typically seen in athletes who do a lot of isotonic exercises. And the clue to that is you will see that other indices of diastolic function as the annular velocities are normal. We look at the left ventricular lung axis systolic function through global longitudinal strain. We nowadays do not need to rely on the S prime velocity or the mitral annular plane systolic excursion. The idea is many patients with heart failure preserved ejection fraction have abnormal global longitudinal strain that is related to their exercise limitations as well as to clinical events down the line. So we want to measure it and report it, as in this example. A particularly challenging group of patients are those with normal ejection fraction, and then you look at the heart, you do not see any abnormalities, be it increased wall thickness, segmental dysfunction, abnormal strain. And then what does one do in this scenario? So we have few signals that are not affected by age. And so if we have one of these signals that is abnormal, even though everything else looks normal, we feel confident in saying that there is diastolic dysfunction. These are signals that rely on pulmonary veins. We will look at that, a Valsalva maneuver. We look at the inflow patterns for the left and right ventricle, and we compare them. Typically, they follow one another. And so if the right ventricle, for example, inflow pattern is consistent with a normal pressure or impaired relaxation, but the left ventricle is one of elevated pressure, that tells us there is a problem with the left ventricle, and we look for the L wave. We do not want to just look at mitral inflow and annular velocities and LA volume and peak TR. We want to look at other signals. That's an example of pulmonary vein flow from a patient with heart failure preserved EF, because this patient has a large elevated LV and diastolic pressure. When the atrium contracts, it finds it hard to send blood to the ventricle. And so the mitral A duration, small amplitude, short duration decelerates fast. In comparison, the atrium takes a longer time with a large atrial contraction velocity in the pulmonary veins. If we compare the duration for that atrial velocity in pulmonary veins with that across mitral inflow, we notice that it's much longer duration, and a difference of at least 30 milliseconds is consistent with an increased end diastolic pressure. Another useful finding in this slide is the pulmonary vein systolic diastolic flow ratio. As LA pressure goes up, that ratio goes down, as you see in this example. There is the Valsalva maneuver during the phase of forced expiration against the closed glottis. Intrathoracic pressure goes up, venous return drops, LA pressure drops, transmitral gradient drops, and we see a mitral inflow pattern that changes from what looks as though it is normal, thus the terminology pseudo-normal, into one of impaired relaxation. This is very specific. So if you have a patient who can perform a Valsalva maneuver and you are able to elicit this response, you can reliably conclude that this patient has an increased elevated left atrial pressure. Another signal is the L velocity. In slow heart rates, when the left atrial pressure is elevated and when left ventricular relaxation is impaired, we see this velocity. Typically, it's more than 50. As in this example, it's slightly more than 60 centimeters per second. I would caution that sometimes you see younger individuals with slow heart rates and you can see an L velocity, but there it will seldom exceed 20 to 40 centimeters per second range. You can also record the L velocity in the bi-tissue Doppler, be it septal or lateral annulus. However, the one we rely on is the mitral inflow L velocity. When we do not have these specific signals that I just discussed, we look at other criteria to arrive at a conclusion of diastolic dysfunction. And here we want to be a bit on the selective side. So we look at the E to E prime velocity, the annular velocities, the peak TR, and LA maximum volume index. If 3 or 4 of these are positive, we call this function. If none or one is positive, we call normal function. If it's split, then it's indeterminate. I will submit to you that if we've gone through all of the other steps, then this call of indeterminate will be less. And now there is a guidelines update that is being drafted that is aiming to help minimize the indeterminate calls. If you have 3 variables, that's enough to arrive at a conclusion if there is a predominance of evidence that goes one way or the other, be it 3 of 3 or 2 or 3. Once we say there is diastolic dysfunction, we want to say whether left atrial pressure is elevated. We rely on mitral inflow, a ratio at most 0.8 with an E velocity that is at most 50 centimeters per second. And a ventricle with diastolic dysfunction concludes that there is normal LAP, but there is impaired relaxation. Grade 1 diastolic dysfunction is the ratio is 2 or above, the E to A ratio. Then we're looking at grade 3 diastolic dysfunction and elevated LAP. In between these, we need other variables to look at, and the guidelines from 2016 refer to the E to E prime ratio, peak TR velocity, LA maximum volume, and in patients with depressed EF, the pulmonary vein systolic velocity to diastolic velocity ratio. If 2 of the 3 or 3 of the 3 are concordant, then we can say based on whether they are abnormal or normal. If the normal range, then the LAP is normal. If the abnormal range, then LAP is elevated. If only one variable is available or 2 variables and there is discrepancy, then we have a situation of indeterminate left atrial pressure. Example from a patient with heart failure, preserved EF, there is restrictive filling, reduced annular velocity, and peak TR of 3.4. So the PA systolic is 46, 47 millimeters mercury at least. When findings are like that, is what you can say is straightforward. This is a little bit more challenging. Someone with shortness of breath, the 2D was not revealing except for the left atrium, but no hypertrophy. We look at the mitral inflow. It's one of impaired relaxation, a TR velocity that is incomplete, and the E prime velocity is reduced. We look at numbers, they fall in the middle category range, but of the 3 variables, we only have 2, and in this case, the 2 are concordant. So we go to the first algorithm, and from the first algorithm, we have 3 variables. All 3 of the 4 of the potentially 4 available variables are concordant. We say there is diastolic dysfunction. Then we go down that middle path and we say this is a patient with a high left atrial pressure and grade 2 diastolic dysfunction. And sure enough, when they are cathed, the mean wedge pressure is 28 millimeters of mercury with a large V and A wave signals in the pulmonary capillary wedge pressure reporting. A patient with depressed EF, we see restrictive filling, minute annular velocities, a TR velocity approaching the 4, the big left atrium, and pretty quickly, without even any actual measurements, we can tell that this patient is going to be grade 3 with a high LAP, and again confirmed by cath when you look at the mean wedge pressure in the 20s, mid to high 20s. The guidelines from 2016 were validated in a 450 patient study sample from multiple institutions across Asia, Europe, and the United States, and they have a decent accuracy at 87%, better than clinical evaluation, albeit you can see that there is room for improvement, particularly so if you consider the group of patients with a normal ejection fraction defined by a cutoff of 50%. There were 241 cases, and here the accuracy was at 84%. The guidelines draw the attention to this group of patients who have a normal left atrial pressure that is grade 1 diastolic dysfunction, but who have symptoms. We should not stop at the rest echocardiogram here. We want to do an exercise echo, what we call a diastolic stress test, to determine if when they exercise their pressures go up, and also because they are elderly and they have many risk factors for coronary disease, that stress test will be an opportunity for us to assess for ischemia. The idea behind the hemodynamic changes with exercise is that with exercise, heart rate goes up, stroke volume goes up, cardiac output goes up. That's a normal heart. The reason the stroke volume increases is because LV contractility increases. But for contractility to translate to increased stroke volume, then LV filling has to be maintained. The reason LV, left ventricular filling, increases with exercise is because the ventricle is relaxing at a faster pace, achieving lower left ventricular minimum pressure, and thus a good transmitral pressure gradient to maintain the early filling. In normal subjects, all of these sequences occur without an actual increase in left atrial pressure. That's an example from a patient at rest. Notice the minimal pressure is close to 0, and this shows us the negative dp dt, which is an index of LV relaxation invasively. At 75 watts of exercise, expectedly ventricular pressure goes up with exercise because we're increasing the stroke volume. But notice that the minimum pressure is now subatmospheric, below 0, because of that fast relaxation and enhanced suction. And notice that the negative dp dt is approaching the 4,000 millimeter mercury per second, much higher than what it was at baseline. So that fast relaxation is the reason for that low minimum pressure. In comparison, this is a patient with heart failure preserved EF. At baseline, it's 1 millimeters mercury, the minimum pressure, with an EDP of 11. They start the exercise. Again, they get higher systolic pressure. But notice that now the minimum pressure is 16 and the end diastolic pressure is 30. The green line corresponds to end diastole. The blue line corresponds to end systole. And so the rationale for the diastolic stress test is some patients with heart failure preserved EF have normal LA pressure at rest. Once they exercise, that pressure increases and they get short of breath. Thus, diastolic stress testing is not needed when the pressure is already elevated at rest, and we would not want to take someone with a high LAP and make the pressure go higher. The tricuspid regurgitation jet should be acquired and considered along with the E to E prime ratio, because it was noted that about 30% of cases can have an increase in the E to E prime ratio, but not an actual increase in wedge with exercise, meaning this would be a false positive call if it were based only on E to E prime ratio. The ideal setting where we have time to image and acquire all the Doppler and 2D signals is the supine bike. And that's an early example, the earliest actually, of the diastolic stress test from Dr. Ha and O from the Mayo Clinic. We notice that with exercise, left ventricular pressures go up. Notice there is no obstruction. Aortic and ventricular peak pressures are about the same, but mean left atrial pressure goes from 17 to 31, almost doubling. If we look at the changes in the mitral inflow and the annular velocities, mitral E increases with exercise, even remains elevated into recovery, whereas the E prime remains reduced, and thus the E to E prime ratio goes up, telling us that the left atrial pressure indeed increased as verified by CAB. This is a study from 2017, again from the Mayo Clinic, showing that both the E to E prime ratio at the septal and lateral side at baseline, at 20 watts of exercise, and at peak exercise, they have a direct significant association with the wedge pressure. So showing you the validation of the E to E prime ratio with exercise. The diastolic stress test that we are referring to is exercise for stress, not dobutamine. Supine bike preferable over treadmill, but if you do the treadmill, we would be relying on the recovery stages. We acquire 2D signals, mitral and flow tissue, Doppler velocities, and peak TR velocity. Be careful that if the indication is chest pain along with dyspnea and even dyspnea by itself, and we are scanning, the priority should be for acquisition of 2D signals because we are looking for wall motion abnormalities. And ideally, the 2D images should be obtained within 60 seconds of exercise termination. As noted, we want to get the peak TR velocity so we can determine what happens to the PA pressures with exercise. To be successful with this test and to get good quality signals and reliable conclusions, experience is needed. The test is considered positive with a ratio E to E prime average of more than 14, or if you are a lab that acquires only septal or the lateral signals are suboptimal, then we want a ratio of more than 15. Along with increased peak TR velocity, please be aware that normal subjects and patients with non-cardiac pulmonary hypertension can have increase in peak TR velocity and PA systolic pressure in the absence of an actual rise in LA pressure. And so these signals by themselves, that is the TR and PA pressures, are not enough to call diastolic dysfunction as the etiology for the symptoms. We need an increase in E to E prime ratio, in addition to the PA pressure being elevated. If you have a patient who is symptomatic and we are not still meeting the diagnostic criteria, it's very reasonable to recommend them to go for right heart catheterization so their wedge pressure can be measured at rest and with graded exercise. It has been shown based on non-invasive imaging, relying on the E prime velocity, that if you take patients with myocardial disease like diabetes, and you see what happens to their E prime velocity, compare it to a normal heart, E prime changes little, does not increase that much in the diseased heart, but will increase in the normal heart much more. That's the example that we looked at for a patient at rest with high pressures, and this would not be a patient we sent for stress test. In comparison, this is another patient who has normal pressures at baseline, E to E, based on E to E prime ratio and a peak TR about 2.5 meters per second. With exercise, E to A ratio goes up. We see a hint of an L velocity. The E prime velocities remain reduced, and the peak TR velocity is approaching 4 meters per second. This response with exercise is enough to conclude that this patient has heart failure preserved ejection fraction in the appropriate clinical setting. Other signals that I look at include left atrial strain, and we now acquire a strain with speckle tracking. The signal that has received the most interest and that has the most data to support its use is the reservoir strain. This is the largest value of strain that we recorded end systole. Strain, like other signals, varies with age, and while useful to think about it, it has a very wide range of what may be considered normal that can pose a challenge if the value falls in within the normal range. Let me show you what I mean. This is a normal subject. If we look at their mitral inflow, looks normal. Annular velocity is pretty high, 15 plus on the lateral side, approaching 15 on the septal side. Global strain normal, 21%. And then you look at the strain, you have a value that is in the middle of 20 to 30 range. If we go to the previous table, it falls in the normal range, albeit in the lower limits. If you go to studies that advocated using LA strain to say there is diastolic dysfunction, if we have values of LA strain in the 20s, then that can be a problem. Let me show you the opposite of this scenario, a patient with HFpEF, pretty high TR velocity, 3.5 plus, E to E prime ratio elevated, but again, a similar LA reservoir strain in the mid-20s. If I go strictly by what is a normal value based on that table that I showed you, and this was a large study multi-center, multinational with a core lab, the WASTE study, where I showed you the normal values, you may be tempted to say this is normal strain. And so if I base my conclusion on that being normal, I may ignore the other signals and come and say, okay, LAP is normal, which, as you see here, is not the case. And so this is the initial data that looked at the validation of LA reservoir strain against wedge pressure and EDP. You see significant associations, but you also see wide scatter. This is a more recent study, 330 patients plus, led by Dr. Nagueh and Chamsi-Pasha, looking at the relation of LA reservoir strain with filling pressure. And you can see that in sinus rhythm, there is a significant association, but with wide scatter, whereas there is no relation in patients with atrial fibrillation, albeit it's a smaller number of patients. If you use that same study that we just showed you the relation of LA reservoir strain from, you notice that the area under the curve and the accuracy of LA reservoir strain as a marker of elevated pressure is lower when EF is at least 50% and is least, in fact, not reliable and not recommended to use if LV global longitudinal strain is at least 18%. That poses challenges for relying exclusively on LA strain and ignoring other signals. This is a meta-analysis from our group showing that in patients with normal ejection fraction, if you do this meta-regression, you see that there is no relation between mean left ventricular filling pressure and mean left atrial reservoir strain. The size of these circles is related to the sample size. And so the largest circles are from very large, from studies that included a really large number of patients. While LA strain is of interest, it is possible to use it as a marker of LA volume and then say, let me get another marker of LA pressure. And so if I combine the pressure change with the volume change, I can talk about LA stiffness. That's an index that was introduced several years ago and has come to more clinical evaluation in the recent years. A stiffer left atrium, so a large change in pressure with a smaller change in volume. So it's the difference invasively between the V peak pressure, V wave peak pressure of the left atrium, and the X pressure, which is the pressure in the atrium after it relaxes, divided by the change in LA volume, which is the difference between maximum LA volume and minimum LA volume. It is possible for us to assess stiffness invasively with the non-invasive counterpart. Recent work from our group showed whether you look at patients in atrial fibrillation or patients in sinus rhythm, there is a significant association between the invasive stiffness and the non-invasive left atrial stiffness in both groups of patients. Also, this is a large study from the Mayo Clinic showing that the highest accuracy for identifying patients with heart failure preserved EF using the invasive criteria as the gold standard was that LA compliance expressed as the ratio of reservoir strain to the E to E prime ratio. What other signals beside LA strain I look at, and we acquire LA strain routinely in our lab? Look at the PA diastolic pressure. The idea is if someone has high LAP, their PA diastolic pressure goes up. And the way we estimate PA diastolic is the modified Bernoulli. So in this case, based on an end diastolic velocity of 2 meters per second, we can say that the LAP is at least 16 millimeters mercury and is definitely elevated. Many patients with heart failure preserved EF have an increase not only in the mean wedge pressure, but also right atrial pressure. And this is a study that included about 100 patients from our group. And you see that nice correlation. Both pressures were obtained invasively. And that's an example showing you both pressures elevated from the patient with heart failure preserved EF. Non-invasively in the lab, we look at assessment of right atrial pressure based on inferior vena cava, its diameter, its spontaneous change with respiration, as well as hepatic venous flow. So I will conclude and say that we always, when we think of diastolic function, we always want to look at the clinical context, pay attention to the vital signs and the rhythm, look at what the heart structure is, the volume, the ejection fraction, the presence of hypertrophy, the lung axis function by a global longitudinal strain. We want to have good satisfactory signals for mitral inflow, mitral annulus tissue Doppler velocity, peak tricuspid regurg velocity, pulmonary veins, estimates of RAP, go for the PR jet and left atrial reservoir strain. Before I rely on any signals, I ask myself, is it satisfactory or not? I apply a common sense approach as what we've, the examples we've gone through. If needed, proceed to a diastolic stress test or cardiac catheterization. Thank you.